delay reasons on all of our delays to the room. So anytime your turnover is more than 25 minutes, or anytime you make it to the room after 7:30, need to remember to put delay reasons. We did remove other OR delay, so that can be your default reason. You actually have to think about what your other reason is. It's just so we can start tracking what our reasons are, so we can try to nail down our prolonged turnovers. Okay, that's all it is. All right, let's start with this. Everyone knows what this is: death packet and fetal demise protocol. Okay, so this is the binder that stays behind the desk up in the file cabinet. This is what you grab whenever you have an expired patient. You have a patient who comes to the OR, doesn't make it. Okay. I recently revamped this entire thing, okay? So it used to be extremely confusing with a whole stack of paperwork. We weren't sure which ones need to be filled out and which ones didn't. So I recently redid it for all of us, okay? So when you first open it, you're gonna notice that there's just an expired patient list. This is just a like step-by-step list for you to do everything you need to do when you have an expired patient, okay? A couple of the things that we need to remember in this is contact your coroner. So the primary nurse, whoever the primary nurse was for that case, needs to contact the coroner. They're going to ask you details about the case. They're going to decide whether or not it's a coroner case or not. If it is, all the lines, IV lines, Foley, central lines, whatever you may have in that patient need to stay in place. Okay? If they say this is not a coroner case and they release it, then all those lines can be removed before the patient's family views the patient's body. Okay? Does that make sense? Okay. So I'll go through a couple more details on that here in a couple of minutes, specifically on patient viewing. The other thing is contacting Life Center Northwest within 1 hour of time of death. So this is not only for organ retrieval, this is also for tissue retrieval. Maybe they can do eyes, corneas, and skin, stuff like that. Okay, so we need to be contacting them within 1 hour of that time of that patient expired. Okay, so this is not just for organ retrievals. Okay, so keep that in mind. All right, so next page, death packet. So this is for adult patients. It says death packet at the top here. I labeled them. This, if you just pull all the paperwork out of this sleeve right here, this is all the paperwork that needs to be filled out. Okay, nothing that is not in this packet needs to be filled out. Okay, something that is not in here that we've always been used to having is death certificates. Okay, that's not actually our job. We don't actually know how we got to the point of filling them out ourselves, but we don't actually have to do that. Okay, it's not our job. It's actually a huge relief for us, okay? So what you're gonna have in there is your expired patient protocol, which again is just basically a step-by-step, so you can check off, I did that, I did that, I did that. Record of death, morticianer's receipt, authorization for autopsy if the patient's family is requesting it, or if it's a coroner case or something like that, okay? So that's not gonna be filled out every time. And then, am I forgetting something there? Oh, tissue release. So, specifically if it's a fetal demise, you have to have a tissue release, okay? And I'll discuss that in the next packet as well. So everything in this packet right here, labeled death packet, is what needs to be filled out, okay? I'm only keeping one of these in here at a time. When it gets used, we don't have a lot of patients expire. So when it gets used, I'll replace the paperwork that's in it, okay? So just find this one, pull it out, and fill that paperwork out. The next one is fetal demise or neonatal packet, okay? So everything, again, in this packet is what needs to be filled out, nothing extra, okay? Remember the tissue release, so if you have a fetal demise patient, that tissue release needs to be filled out if those parents want that tissue to go to a funeral home after it goes to pathology or something like that, okay? Very important that that tissue does not get thrown away or something like that. You have to have that receipt filled out, okay? After that is a memo from Genetic Laboratory from Shodera. This is if the parents of a fetal demise are requesting some sort of testing. We don't do it a lot, but this kind of explains that if they're requesting that, okay? And they are notified of that, probably not by us though, I can't remember who notifies of them of that. The lab does notify them of that. So it just kind of gives you information on how to go about that, okay? Beyond that, the next section is extra forms. So if you're missing your record of death or your tissue release or your authorization for autopsy, it's gonna be in this extra forms section, okay? I have all the forms that are in those packets. If you're missing any of them, that's where you're gonna find them. On the last page in here is chaplain contacts, okay? So if we're gonna allow a patient viewing with the family, chaplain contacts, have one of them come by and just be with that family during that time, okay? If we do viewings for families, that takes place in AMADMIT, okay? Does not take place in PACU, doesn't take place in the OR, okay? So after we figure out whether or not it's a coroner case, whether it is or not, whether you leave the lines in place or you take the lines out, get that patient as cleaned up as best as possible, okay? And this is where the techs really come in handy right here, is because the nurse is going to be doing a lot of other paperwork and stuff like that, okay? It's very stressful for a nurse, it's stressful for everyone, okay? But the best thing you can do at that time is help get that patient ready to be viewed by that family, okay? So we get them cleaned up, we fix their hair, we try to get all the blood off of them. As morbid as all of this sounds, we want to make that viewing as good as we possibly can for that family, okay? That patient's then taken to AM admit. Typically we go into AM admit room 10. That's not set in stone, but that's kind of the room that we tend to gravitate towards, and get that patient ready for that family to view, okay? Again, they can view whether it's coroner or not coroner, doesn't matter, okay? After that patient is viewed by the family, you can call transport, they'll bring you a shroud and they'll get that patient down to the morgue, okay? Any questions about that? Yes?
How about in the case of organ retrievals like PCDs, ICUs? Should start it, we should finish it, we should start it and finish it?
In terms of what, the paperwork?
Yeah, exactly.
All that stuff should be completed already. So those patients have already been pronounced, not alive at that point, so that death packet
Not
paperwork.
in the case of like a DCD though.
You'll never have a patient that expires in the OR that's a DCD candidate.
Okay, so our last case did not do paperwork.
So that's different. So that's an ICU patient. This is what Blake's going over is just patients that die in the OR.
Okay.
For a patient to become a DCD candidate, that's donation post-cardiac death, everything has to be tested, right? All blood work, all the organs have to be assigned to a transplant candidate. So those patients are kept alive essentially until all of that is done. ICU doesn't do the paperwork. When everything gets turned over, a different D number is created on those patients upstairs. Life Center then takes over at that time. So that's all Life Center's responsibility is to do all of that paperwork. Yeah, so you'll never have a patient in the OR that expires. The only type of candidate that they can be is a tissue and or eye donor. Yep.
So we should not, what you're saying is we should not have to do this paperwork for any organ retrieval?
No, never. The only thing you guys have to do is a call to Life Center Northwest. That patient, let's say family does consent to do donation for tissue and eye, patient goes to the morgue. That team flies in, they go get the patient out of the morgue, go upstairs, no different than any of other tissues. Yep. Good question.
Any other questions about this stuff? Okay, a lot of these meetings and stuff, once you have a patient that expires, you don't remember these details, you don't remember your step-by-steps, okay? So follow this as best as possible with this step packet here, okay? And then if you have any questions during a time like that, it's incredibly stressful, so you can call Brandy, you can call myself, we'll help you through it, okay? All right, moving on from that, mass transfusion protocol. So who's heard of a mass transfusion protocol or really knows what exactly it is? All right, so mass transfusion protocol is used to prevent coagulopathy in a patient that has typically experienced trauma or hemorrhage. Patient is in need of large volumes of blood products. It includes 6 units packed red blood cells, 6 units FFP, and 1 pack of platelets. This is called a whole blood replacement, okay? So that's all the components of an MTP. This protocol was developed to streamline the MTP process and provide the care team with the necessary resources, okay? So this entire process has been extremely cloudy. In text, I'm gonna kind of explain what your role in these situations can be, okay? But right now I'm talking specifically to the nurses. When an MTP is ordered by a physician, it's called overhead like a code, okay? So we've done it a couple times since this has been put in place. So you may have heard mass transfusion protocol heard overhead like it, like they were calling code blue or something like that. When they call that overhead, they call out the location, and a staffing response team is dispatched to the area of the MTP. So if we were doing it, they'd say MTP, OR, staffing response to OR, okay? That MTP must be ordered in Meditech, okay? And this allows all the blood products to start getting processed. This allows any laboratory tests to start getting ordered and stuff like that, okay? Blood products are administered through a rapid infuser. Let's see. Oh, one more thing on this. The staffing response team members, one of them is going to be dispatched to the blood bank so that they can retrieve those products for you, okay? So when we call an MTP here, we should not be the ones sending someone to go get those. One of those staffing response team members should be going to get those blood products for us, okay? So we don't have to send one of our staff members. Typically, we run blood products through a rapid infuser like our Belmont. However, anesthesia, a lot of times y'all know anesthesia doesn't really like to use Belmonts here in the OR, so they may have those started in ER. If they start an MTP there, we may bring them over on that Belmont, but we probably won't initiate on that Belmont if they're not already on it.
We pulled Belmont, so no Belmont in use, but they'll use, everybody has the rapid transfusers. Yeah.
All right, mass transfusion tracking form. Have all the nurses seen this before? Okay, have you used them? Okay, so this only allows spots for 5 blood products, so 6, 6, and 1. So you're gonna obviously need more than one of these. Okay, so these come with your blood products. If these did not come with your blood products, you need to call blood bank and say, I need my MTP forms. Okay, they should send you at least 3 of them. All right. They should send you at least 3 of them. If you don't have 3, you need to ask for more. Okay? This allows you to keep track of your blood product numbers, the time you administered, vital signs, because all that stuff still has to be charted in Meditech. Okay? In our TAR documentation, we still have to chart all that stuff. Okay? It's not going to be done until later. All right? So this is allowing you to help keep track of all that stuff. All TAR documentation will be delayed until it can be completed at a later time. Again, it must still be completed. So save all your blood product bags. This is not only for your help, but this is also a rule that we put in place. All those blood bags will be sent back to the blood bank. Okay, just like we used to do. If you're given 1 or 2 products, you can still throw your bags away. But if we're doing an MTP, all those bags need to go back to the blood bank. Okay, and also just save them for your own good. During an MTP, 2 licensed individuals who initiated the MTP, so this is saying 2 licensed individuals because you have to have 2 people checking the blood if it's cross-matched blood. So they actually have to stay with with that patient in those products until the conclusion of the MTP, or if the MTP is discontinued. Okay, so if we start an MTP down here, we're given the 6, 6, and 1, we take that patient up to ICU, we either have to stay with that patient while that MTP is being carried out, or we have to discontinue it so that we can take the products that we have with us. Okay, we can't leave products that are under our MTP up on ICU. Okay, does that make sense? Okay, to tell you how to get around that, don't order an MTP. Okay, if there's any way to avoid it, you're either gonna have to not order one, or you're gonna have to discontinue as soon as you get somewhere. Because if you're on a weekend and you're the only nurse here, or it's in the middle of the night, and you're running an MTP and you're upstairs with a patient, another trauma comes in, you're screwed. Okay, so you can discontinue, take all your products with you. They can then start a new one on the receiving unit if they need to, if they want to, or just don't start an MTP. Okay, you can do whole blood replacement, 6, 6, and 1 still, without ordering an MTP, but you're gonna screw yourself over if you order an MTP at Meditech. Does that make sense? Yeah, clear. Got it. Okay, so at the conclusion of the MTP, all TAR documentation must be completed. Still, for all blood products, you have to have 1 post-transfusion vital sign for each product given. You do not have to have a pre-vital sign, okay? But if you go through all your TAR documentation, look at your product and it says transfused, then press on that, hit document vitals, and you need to put 1 post-vital sign for every product given, okay? I choose 1 vital sign, and I give that same vital sign for every single product given, okay? I don't care, all right? You could say 98.6 for a temperature. Doesn't matter if it's a temperature or blood pressure. You just have to have 1 vital sign, okay? All we're doing is trying to satisfy the system with this, okay? All of our vitals are tracked through anesthesia. We're not actually concerned about that patient's reaction because they're watching it constantly. Just satisfy the system and put in 1 vital sign for each product, okay? Does that make sense? I don't care what the vital sign is. You can do respirations and they can be on a perfusion for all I care. Okay. An MTP can be discontinued at any time regardless of which products have been received. So this is how you're going to get out of having to stay with that patient, okay? Discontinue your MTP if you can. Take your products with you. Don't leave those products with them, okay? Blood bank's going to be looking for those products that they gave you specifically, okay? A new MTP can then be started by the receiving unit, okay? Flew through that, but does anyone have any questions on that stuff? Yeah.
So you can do half, say you give 6 units of blood, can you discontinue and then take the units back up to ICU? Or
No.
You can discontinue, but you have to take whatever
You
you
have
have.
Oh,
Yeah.
gotcha.
So if you're hanging 6 packed blood cells and you have number 6 hanging right now and you take that patient up, you're discontinuing, you have to take that empty bag down. Okay, so you can discontinue, but whatever's running right then, you do have to complete that bag and take it downstairs with you and return to blood bank after doing your charting. Okay. Any other questions on TAR?
Do those sheets go back to blood bank?
Yes. Yep, these need to go back to blood bank. with
And
your empty
are they
bag.
have to be like signed, right? Is it-
There's RN1 and RN2 signature down here. You can do RN1 and then some, if you check it with anesthesia or whatever, just do TAR down there, TAR
I
anesthesia.
had, one time I did this and they were wanting the signature from the provider who ordered the mass transfusion protocol, and at that time, the surgeons were gone, so it's like, I don't have anyone to sign. So
Was
it's
that for
very confusing.
MTP or was it for the uncross matched units? Because they do require physician signature for uncross matched units. So they shouldn't ask for a physician signature because we're putting in an order in Meditech for this. So if you're putting in that MTP order on Meditech, same fax written, whatever, they're gonna have to sign it electronically anyway. They will probably require a signature for uncross matched units. So that may be what they were asking for, but you just need RN1 and RN2 signature on this, okay? Yeah.
Is there any way you could have copies of those here that we could get in case they don't come with the blood?
Yes.
Number one.
Anything around
And
that,
number
nothing around that.
2, I had saved a bag of blood products that were given not by me but by someone else so that they could chart them in the morning. I put them where the specimens were, and they got tossed along the way, and I'm wondering where a safe place is we could put that to communicate, please don't throw these away until the next nurse comes.
How often does that happen? Just out of
Okay, I only
curiosity.
did it once and it happened once, so 100%.
But if nobody got I mean, how often are we saving bags for the next day to be charged on? You think it's safe to just say if we put them in the specimen box, we should explain to pathology not to take empty blood bags?
Yeah, I know that, but it was like 2 in the morning, or
Yeah, no, I
whatever
think it's fine.
time
No, I just
we
mean
put
if we
the-
give them a heads up now, hey, if you ever find blood bags on
Oh.
the pathology box, don't take them. They're not specimens. I think we could probably explain that.
But I don't know if that's who did it. I'm just saying that's where I put it,
Sure,
but when the person came in the morning, they were gone.
okay.
So I don't know where they got lost along the way.
Honestly, if you guys have them in a biohazard bag,
It was in a
and
biohazard bag,
I would just put them in my mailbox.
outside
Or-
your door.
Yeah, or
Okay.
Jeff's mailbox, because
Okay.
it's always we know immediately, and so then we can, one, speak to it of, yes, the blood bag is here, we're waiting for somebody to come in and document on it, so I bet that's the safest.
Yeah, you just
Okay.
put it in the mailbox.
Yeah, mine or Jeff's, and we can help you guys deal with it the next day. That way it doesn't get taken or thrown.
And then I'll keep a bunch of these over here, maybe just where the extra paperwork is up by the front desk, where you find like path sheets and stuff like that. Okay, so I'll print off a bunch of these and keep them up there for us, just in case if we don't have them in that situation. Okay. Yeah.
This is just out of curiosity and probably more for Brandy, but is the hospital, like, do they always have like an MTP kind of backup? Like, I've heard where we only have like 1 platelet in the hospital or something. Do they
Yeah.
have a- Like, what happens if,
So the problem that we're having is the Red Cross shortage.
Right.
Red Cross is who we use, and it's a national shortage of platelets. So we, as an organization, we can only get what they will give us. So it depends on the day of what they have. So we went in on Friday, and we only had 1 unit, and we were going to get more released from Red Cross at 9 o'clock. So what happens is that blood bank alerts us right away of where we're at. Currently, then we reach out to the surgeons and say, hey, this is what we have right now in-house, and you have 2 hearts going on, but we have more released at 9. So really, from an organizational stance, we can't, it doesn't really matter.
MTP and we don't have any?
Yeah, so then you don't have a whole blood replacement, essentially is what that
So you
means.
would just do like a regular?
Yep, they may give cryo, they may give albumin, they may give other products. That's the one thing with anesthesia that our trauma program is really trying to work with them on, is that you guys know, no different than a code. We run our codes completely different than ACLS runs their codes. And so anesthesia sometimes runs their blood replacement differently. They're getting a lot of pushback from the trauma program that you're not doing a whole blood replacement, so you're not benefiting the patient. So that's something that Dr. Ingen and the trauma program is working on. So platelets are an issue though, for sure, nationally.
And BioLife doesn't go to
Montana.
replacement, well, it doesn't go to replacement, it
Oh.
goes to like medications and stuff, just an FYI.
Really?
Cause I work for BioLife, so just an FYI, if you're given plasma or whatever over there,
Didn't know that.
not to patients, it's for other issues.
All right, as far as techs go during MTPs, these are extremely busy cases. These are usually trauma patients. If you're not scrubbed in, running is probably going to be the best thing you can do for us. Okay, so running and grabbing products and stuff like that. Like I said, we're not going to use MTP a lot here, so we're not going to have that staff and response team. So our extra techs are going to be the ones that are probably going to be grabbing units for us and stuff like that. Okay.
I guess I do, I don't really know like how to question this, but so the one time I had it, it was called up in ICU when we were up there getting the patient. And so then it was called overhead, and we brought him down, and I was getting phone call after phone call of people like, I can't get in, but I'm here to help. I can't get in, like, cause it was after hours, so the door was locked, and I was like, I can't go let you in then, but look, we have enough people, but how do you like address that? It's like in the OR, should we have like a certain like staff and response people who can actually get into the operating room?
No, and I think we face that a lot. Like I've called Code Blues in the middle of the night when I didn't have anyone here, and having people come down that wanted to help, and at that point I really didn't need help, and I just started turning people away. At that point I think
But that
it
was
would
just
be more of
like-
a hindrance than anything else.
Yeah, phone call, and I was like trying to do stuff and still answering the phone, and
I would have patient flow be your biggest resource, to call them. And one, if you do need help, to get people in, because I don't want you guys to not do it and then really need the help and not have the help that you need because we've turned everybody away. So I would engage patient flow to come help in those situations. They certainly can get a bunny suit on and just field those phone calls for you, and help turn staff away. Usually at night, it shouldn't be a huge response. Probably ICU, your code team is probably your biggest. And then there's a manager, clinical manager, always on call as well, that'll come in and help. But unfortunately, there are also staff amongst other areas that want to know what's going on, and so their intention is not to come help, they want to know. And so just that feedback to me would be great if, you're getting inappropriate calls. And really it should just be ICU patient flow and ED probably responding, Mercy Flight if anything, if they're in-house.
So Blake, if the transfusion protocol is called in the ER, then what you're saying is that somebody from the ER needs to come with us and stay until
That
all
nurse
those
that
blood
started
products
that
are
MTP
given?
has to come with you. Yeah. And they're very aware of that, especially in the ED. So if they're not, call Kevin
No,
Lynch.
I just,
I'll
I had
for
it.
him to hear.
I had it one time with that sheet that came up with a patient and like a bunch of blood bags, and I was like, what do I do with these? So I just took them back to the blood bank. I mean, I was like, I didn't give these units. I'm not putting my name on it.
Yeah, exactly.
So,
So, yeah, you did
but
right.
they,
If they weren't.
they were all right
distributed
with
to
that,
ED.
but I was just like, the actual
So did you
proper thing to
continue
do
that
is here.
MTP? Or did you DC it?
No, I didn't personally DC it, but, cause I can't do that if I didn't start it, right?
How many have we actually initiated?
In the
I've
OR?
never
Yeah,
initiated
Zero.
one.
Yeah, so I mean, 99 times, it's gonna be that it's initiated
Yeah.
somewhere else,
Yeah.
it's just a
I
matter
just
of,
remember
they're
coming up
probably
with all
coming
the
our
papers from
direction.
the ER, and I was like
Right.
looking through them, trying to get them organized, and there was the mass transfusion sheet, and I was just like,
The two times that I've done MTPs, they started in the ED, and Zach Strickland started them, and he came down with me
okay, cool.
and took responsibility for all those units. So they should be very aware of the fact that they have to stay with those units. Then.
Okay.
if not, you tell them.
Yeah, exactly.
Okay.
And then tell me so I can call Kevin, because I really can have that conversation with him. Okay, any other questions about MTP? Okay, all right, discussion time. So we're gonna talk about count policy real fast, just one specifically. So recently came up, Danny kind of talked about it a couple months ago, about hysterectomy counts. We have never in the past done instrument counts for vaginal hysterectomies. We have never in the past done instrument counts for laparoscopic hysterectomies. Of course, we do them for open hysterectomies. Okay, so now I'm going to show you what our policy states and what AORN recommends, and we're going to decide what we want to do when it comes to hysterectomies. Okay, so our policy says instruments will be counted for all procedures in which the likelihood exists that an instrument could be retained in the patient. Pretty vague, right? Leaves a lot of room for interpretation. Okay, so basically at your own discretion you get to decide what cases you're going to count instruments for. Now here's what AORN recommends. Okay, these are all the recommendations in their counting section, all right, that pertain to what items are to be counted, which are not. Again, account for instruments in all procedures for which the likelihood exists that an instrument could be retained. Okay, that's literally cut and paste to our policy. Count instruments for all procedures in which a body cavity, thorax, abdomen, pelvis is entered. Okay, this is kind of what we need to talk about. Professional organizations recommend that healthcare organizations determine which instruments will be counted and which procedures will have instrument counts, to include procedures involving open cavities. Okay, so this is allowing us, again, to decide for ourselves. Okay, so take ownership of this policy and decide what you want to do. Last one, establish a policy for instrument counting. The WHO and the ICSI recommend that healthcare organizations determine which instruments will be counted and which procedures will have instrument counts. The ICSI provides further guidance for healthcare organizations when determining instrument count protocols, including consideration of the size of the instrument relative to the size of the wound and the visibility of the item throughout the procedure. I looked at the ICSI. They do not say anything specifically about hysterectomies, okay? So that's not going to be any help to us specifically, okay? Down here at the bottom, this is something that AORN says in their recommendations. The benefits of accounting for instruments outweigh the harms. That's just something to consider. I'm not trying to sway your opinion one way or the other. So, in my personal practice, I've never counted instruments for laparoscopic or vaginal hysterectomies. Always for opens, okay? So I'd like you to tell me, what do you feel like we should be doing? Should we be counting instruments? And think about this right here, where it says, consideration of the size of the instrument relative to the size of the wound and the visibility of the item throughout the procedure. How oftentimes do you lose sight of an instrument during a vaginal hysterectomy? Do you ever? Really? It's always in your hand, right? Okay? The only time that you just don't lose sight, right? Okay. So, what are some of your suggestions? Who has some opinions? Yes?
I say no, because of that reason. Usually in a vag hysterectomy, you can't even get the tip of the needle holder in,
You can't get anything in
or to clamp.
Okay.
And I've seen them clamp like 100 times into that space because it's so tight. Before I came to this facility, I did a lot of vag hysterectomies, because that's the way they used to do it in the old days.
Right.
Never did we count, never did we have a retained object.
Okay.
I think if it was a problem,
Sure, if it became an issue, then maybe we need to
Yeah.
look at it further. Okay.
I don't see it, and I don't see it on the laparoscopic system. That's
Neither
why.
do we. Okay. Anyone else? Karen, you agree with that?
I agree.
Everyone seems to be in agreement of that.
But with that being said, when you have traumas on the weekends, and even like a DNC, and they say a possible abdominal hysterectomy.
Oh, absolutely.
You need, well, this happened, you need to get that abdominal hysterectomy and you need to count that in. Because when it goes open, it's gotta go open for a
Right
reason,
now,
and it's
yeah.
like a huge issue, so with that being said, but I say no county
Yeah.
planning.
If you've never been in a DNC that ended up going into an open hysterectomy, then that's one of the scariest cases you will ever be a part of. Okay, because usually you have a childbearing age female on the table that probably has kids already or just had a kid, all right, and she's about to bleed out right in front of your eyes. Okay, so one of the scariest things you've ever faced in your entire life. Okay, so I would definitely be as prepared as possible and count that open hysterectomy set.
But I say,
And if you can't in that situation where it becomes so emergent, X-ray at the end of the
yeah,
case, right, and
absolutely,
fully
but at least
documented
set up.
that it was emergent, could not do counts. But if you have the time, you take that time.
All right, so this is not going to be written into our policy. This is just so we're all on the same page that we do not require instrument counts for laparoscopic or vaginal hysterectomies, okay? It's still gonna be at your own discretion. If that patient situation, for whatever reason, you feel like it's gonna be best practice to do an instrument count, then maybe your situation's different than the rest of ours, okay? That's gonna be at your own discretion, okay? That's why we're licensed individuals, yeah.
Not to complicate things, but we didn't used to count the green bulb until one got left inside somebody.
So that is part of our policy. Actually, it's in the policy that green bulbs will be counted. So that is it's outlined.
But I think what you're saying is.
Oh,
yes.
Not a problem until it's a
yeah, we'll get it.
Fuel on the fire.
So
And I
what-
think that's where we have to use our discretion, right? No differently than a pediatric umbilical hernia. You know, we're not counting those either, and so that's where we use our discretion in why we're not counting it, and that's because you can't leave something in that area. Because otherwise we would be counting on every procedure.
Okay, anything else, guys? All right.
All right, have a good day, you guys.